afternoon, Dr. Mustafa, Dr. Saab. It's George Pliagas coming in. We've got a friendly panel, guys. We're here. We're very excited about this third live case from Grand Rapids. I want to thank you and Dr. Saab for putting on a fantastic live case display today. And I also want to thank all your accompanying staff in the background that are assisting you and taking care of you. So
thank you, everybody from George.
To all them as well.
Thank you.
I've got a few introduction things. We'll get right through it. Number one, Dr. Mustafa, congratulations on your 10-year anniversary of the AMP. You've done a fantastic job. We all thank you very much.
Thank you.
We've got a great panel here with Paul Michael, Martin Knowles, Kumar Madassari, and of course, Brian Fisher, just down the road here for me. And we also want to thank Philips for this CME approved activity with their educational grant from Philips. We put on this live case symposium of the use of intravascular ultrasound and endovascular ultrasound to enhance our CLI treatment algorithms for best patient outcomes. Again, thank you, Philips. So I'm passing it off to you, and let's hear about the case.
Oh, thank you, George, and thank you for the esteemed panel that you have today. We definitely have the case to demonstrate the value of extravascular ultrasound and intravascular ultrasound in combination too. So with that, we start with our first slide, please. That's my disclosures. All right, this is a 69-year-old male with, when we say from out of area, patients drive about 8 hours to get here, with history of multiple revascularization because of CLI over the last 2 years. Diabetes, coronary disease, and CKD. Stage 3, as we presented earlier today, looking at the predictors of mortality and major amputations, actually CKD was one of them, along with diabetes. So this gentleman have both simultaneously, hyperlipidemia, and also has left first and third 2 amputations. Next slide, please. He's here today because he's got severe tibial pedal disease. And the CTOP analysis that we presented today, based on that, he's got type 3 and type prime 3 and prime 5. And that makes him a target of being at higher risk for major amputation and mortality. So really, the more we learn about CLI and associate it with different type of lesion characteristics or CTOP analysis or things like that, what we only find in that more mortality, the further the disease is. So in this case here, this patient has the worst type of CTOs. They're in the tibial arteries and the pedal arteries. Let me show you what we did so far. The first angiogram that we took. We started by, again, integrated access, and we took a look at the SFA and the profunda, and we stuck the common femoral artery above just above the ostium of the SFA. SFA looks reasonable. And then the popliteal through harness canal. Now, remember, this is an angiogram, so we're going to take an IVUS shortly and see what's going on there.
That's a great point.
Here's the popliteal tibial junction, right? Clearly, there's a questionable high takeoff of the PTE questionable, and the AT is occluded proximally, and the perineal has some disease in it. And the next shot should show us any reconstitution of these vessels. Here's the next shot. So I hope I made your day by showing you that this is a very difficult case. And that is actually what we deal with on a regular basis. We didn't really go and look for cases for today. This is just regular patients that were scheduled.
That's very true. That's very true. You have great. This is the kind of case you get up in Grand Rapids all the time.
Our partner, Dr. Einstein, calls them ACV specials. So with that, we plan on doing dual retrograde Schmidt access. Basically, again, access in 2 occluded tibial arteries from below, and in hopes of getting through the tibial arteries and then reconstitute the pedal loops. So bear with us as we start. And then in the meantime, while Fed is doing that from below, I'm going to get into the AT from above and try to help Fetty somehow. So,
well, that's great.
Any comments so far?
Well, you've got two good, obviously you're doing a great teamwork technique, guys. I mean, he's got somebody from below and somebody from above to go ahead and go after these very difficult lesions. Martin, what do you think about a dual technique? Do you ever use it in your place?
Yeah, this is you can't ever argue that we're not that we're just showing the easy cases. This is a tough case. Obviously you've got distal reconstitution via your perineal, and you don't really know whether you have just hibernation of those vessels. I think that's where ultrasound really comes in very, very helpful. And that vessel actually looks much better than I would expect it to, based on what we saw in the angiogram. So I think, at least starting with one, maybe not both, is a great idea for this retrograde access, and see what you can do. In general, I think the ultrasound really, again, I've said this, the ultrasound really will add value at this level to tell you what you're looking at, because often, these vessels are spared and you're able to get up and get a pretty good approach retrograde this way.
That's a great response, Martin. That's a great response. Yeah. So we see that Dr. Saab is trying to get into that distal part there. So
trying is the right word.
So both vessels are occluded, guys.
George, this is going to be challenging actually for Freddy, but challenging for everyone who's going to try to do this. Maybe. Yeah. He's trying to get into the PT, and I'm going to wait here to see if he gets into the PT, then I'll engage the PT. If he gets into the AT, the DP, then I'll engage the DP. Sometimes, the question that we get asked, why don't you work on a different artery? And then if you cross integrate, then that way he crosses retrograde and I cross integrate. We used to try that. We find it more efficient. As my colleague just finished saying, maybe focus on one artery today and get it finished. That is why we focus on one artery at a time.
Dr. Mustafa, that some of our colleagues try to do this without the use of ultrasound, extravascular ultrasound for access. What are your thoughts on that? And do you always use it? Can you tell us your opinion?
Yeah, George. We published a paper with 900 patients in it. Looked at ultrasound guided tibial pedal access common femoral artery versus fluoroscopy, and the complication rate differential was significantly high, statistically significant. So with ultrasound, you can see the artery, as you can see here, and instead of poking around into the veins multiple times, you just stick the artery directly. So I find it difficult for me to accept the fact that we still do a tibial access without ultrasound, but again, George, you can only do the data and publish it and then wait for the adaptation.
Maybe more superficial, I can try.
You're right.
How can someone do this under angiography? Because the artery is not filling and it's spastic and negatively remodeled. You see that?
Right, right.
Almost completely collapsed. So actually, Freddy has to stick this almost 35 thousandths of an inch, basically occluded lumen, and put 18,000 of an inch, 18,000 of an inch wire in it. So let's see if you can do that.
Dr. Mustafa,
why is it
question about the Schmidt technique? If you have a few words just to describe it, somebody from the audience had a question about that.
I'm sorry, which technique? The Schmidt technique?
Schmidt, yes.
Yeah. So the Schmidt technique is, our friend Andre, he used to inject and then basically stick either the SFA or something else in an open segment. But we actually adapted sticking what we're doing right now, sticking an occluded artery that doesn't have any lumen in it, and advance a wire through that. So we named it the Schmidt technique. So basically, it always means that you stick in an occluded artery and put in a wire in it and revascularize it, actually. Without this Schmidt technique, actually, we would not be able to revascularize the number of patients that we do actually revascularize.
Those are great points. I mean, we know from the literature that approximately 20 to 30% of cases cannot be accomplished because we don't have appropriate access. And I think once you get the skill set, as you said, to get retrograde and antegrade access, then you can raise your your success rate up to almost 95%.
Absolutely, and that's what happened with us before the Schmidt access. We had a high success rate, but with the Schmidt access, we went up significantly actually. I recommend anyone that has CLI interests to adapt the technique. I mean, you can see clearly it's not easy, right? It's not something you can just go ahead and do. You need to have a good ultrasound technician with you, and then also a physician who's patient that is willing to give it a try. As you can see, the vessel is negatively remodeled.
Right.
And it's going to take some work for Ferry to get through this.
Well, while Dr. Saab's doing that, Paul, down in Florida, do you use extravascular ultrasound routinely to get access?
So Jihad, I'm going to use another needle. I'm going to use the first needle to trap the vessel.
Okay. That's a good, hold that thought, Paul, hold that thought. So he just said something very interesting. He's going to trap the vessel with another needle and try to get another needle because it seems like it's migrating away from him every time. If you notice, everyone, and Jihad, correct me if I'm wrong, basically that other needles provide some support, some background support. Is that correct?
Yeah, so actually if you can see my hands here, what we normally do for this technique, you take two needles and you try to stick the artery, but the artery rolls. And as it rolls, you go into the adventitia. So you just keep the needle there. And you do it again, and the artery might roll the other way. And if it does, you stick the adventitia again. So actually you pin it down with two needles like this. And then you get the third needle and you go down in between. And that is a very good technique. Most of the time it's successful. So Freddy got one needle in already. The second one is going in right now. If he gets in the artery, it's good. If not, you get the third one and go in. So nothing else that he can do. That's the only options he has. The other options, I go do it. Then we'll get it done. But I have to wait till then. Yeah.
No, not
so one thing that actually against Fadi here is the integrity of the artery is not the best. So sometimes you look at the integrity of the artery and it looks like there's good medial calcium, there's circumferential artery, but the lumen is occluded, but there's circumferential to it. In this case here, there's negative remodeling. So if you're talking about complexity or end-stage disease, this is it. So we picked something that is not going to be easy to get into because we want to show you something worthwhile.
That's a good point. And for those of you listening, we're going to go over to Paul for a second. Paul, do you use it routinely down in Florida?
Oh, absolutely. More than routine, it's the standard of care. And I think the adaptive change that we've showed, through the literature, it's just common sense. So I think Dr. Mustafa is absolutely right. It's sad to see that that's not the common sense strategy anymore. The other thing I wanted to comment, Dr. Mustafa was mentioning integrity of the vessel. When it comes to chronic wounds, that severely affects the integrity of the vasculature as well. So just an additional component besides calcium,
let's go to the DP or AT.
The scar tissue around, the multiple debridements. That is one of the few things that makes the case non-successful.
It can be, you're right. Brian, what about you in Nashville? Do you use it a lot?
Ultrasound guidance is the gold standard, and I learned from the guys that are doing this live case right now. Never look back. It allows you to do so many different things to address true CLI. If you're going to be a true expert, I think this is where it starts. Multiple access points. Again, this is where I got my start, so it's really cool to see. And in Fadi's defense, this is almost an inaccessible vessel. This is going to be really, really tough, but I'll bet he still gets it.
I agree. It's what I like what Paul said too, guys. Standard of care. It's just and I know right now you can argue. There are several people around the country that'll argue it both ways, but I do think if you're going to do CLI work with the amount of calcium we see in these walls, and there we go, Fadi. There you go.
Nice.
Very nice.
Nice job. Very nice.
Told you.
Yeah.
There you go. Just took a few words from Brian.
Yeah. Well, it's really worth watching it though. How long it took for him to get it, and it's definitely going to make a difference.
I still don't have a lot of purchase.
So he's only got some purchase, not a lot, and he's going to figure that out. So we're going to do IVUS from above as Ferry works on it below.
Right.
Here you go. This is the SFA. And remember, the angiogram looked nice and clean.
Do you want to show the loop under ultrasound?
Yeah. Can you guys switch to ultrasound for a second, please? So Freddy's trying to create a Janelli loop. There you go. That's beautiful, actually. Now, all you have to do is rotate it. That's
Correct.
awesome.
Very
See how
nice.
it's
Good
propelling
job.
itself forward. Actually, on Twitter, there's been a few questions about the Janelli loop. And look how it keeps itself in the vessel. And you do it clockwise and counterclockwise, and it kind of keeps centering itself. This is beautiful. It's a great demonstration.
Well, the addition of the addition of extravascular ultrasound and that you guys are adding shows you that you're staying true lumen, and that's the perfect tangent right there.
Yeah, absolutely. And if it wasn't for the ultrasound, this case would not be actually done. It would not be successful.
Exactly.
I got to tell you right now, it's impossible. I mean,
100%.
nothing is impossible, but
CXI, we have it.
I guess it'll be very difficult.
So
And
now,
here's
what are
the
you
SFA,
showing us? Yeah.
Here's the SFA and the pop
Carl,
right
do you
now.
mind magnifying, please?
Sorry?
Do you mind increasing the... Oh, your IVUS. Never mind.
Yeah, I'll write it down to you. This is the area in the pop right here when we... So like some narrowing. And the question is, you know, when you have critical limb ischemia patients with the runoff that we have, would you treat lesions that are in borderline of 70% or not? I mean, do you leave them alone? Do you treat them? And if you do, how aggressive are you going to be with them? So here's a lesion right here that you may treat or may not. It depends. Remember, there's no good flow distally. So I'll leave that for discussion with you guys. Here's another one.
Yeah, keep working. We'll talk about it here. And let's
and here's another
see.
one right here.
George, I'd love to
get
a chance.
An angiogram, it doesn't look bad, right?
No.
But here, it looks, you know, maybe something needs to be done about it. So we'll keep moving. And it's very interesting, right? The P2 has a tight lesion, and the P3, here you go right here, that says take off the posterior tibia right here.
Change the MAC to 17.
Now the
to
P3.
14. Change the MAC to 14.
Or maybe the TPT, now I don't know what you want to call it. And it looks like reasonably okay. And as we go into the AT, and the AT has disease in it, and the wire so far looks like in a true lumen, but it looks like for a second there was in subintimal. So what I'm going to do actually, as Fadi is coming back from below, I'm going to use actually the IVUS to cross, and Fadi is going to use the ultrasound to cross. So that's actually a good combination.
How far I am down from you, Jihad?
One of us can use IVUS guided crossing and use ultrasound guided crossing.
So talk about IVUS mediated crossing a little bit. That's a new technique and a new concept that many of us aren't aware of. Talk to us a little bit about it.
Yeah. So they're doing, actually, they're not using the fluoroscopy, so I can do that right now and show you.
Okay.
Here you go. So let's go back to IVUS, please. So, yeah. So with IVUS, here you go. The wire is advanced, so I'm going to advance the IVUS. And it's showing me that I'm in a true lumen so far.
Okay.
And then I'll pull the wire back, unloop it. So let's put the fluoro somewhere. Here's a loop at the distal portion. Pull it back, and then advance it. And then advance the IVUS again. And it gives me comfort that I'm still in the lumen.
Very good.
And then pull it back again, the wire. Because every time you pull it, it looks like Fedi just passed by in the subintimal space. So actually, I'm more in the lumen than Fedi is. Because of the IVUS, right? The IVUS gave me the advantage here. I don't know, he's not actually. Hold on a second. Let me see where Fedi is. So we're gonna go contralateral oblique. Actually, we can't see it in the ipsilateral oblique.
But I mean, at least if you know where you are, if you know that you're in true lumen where the tip of the IVUS is.
Oh my God. George?
Sorry guys, Jihad is trying to kill
partner?
the staff. So maybe we can do the tunneling where the tip of the IVUS is and pull my catheter back. You know, retrograde dissection, retrograde even perforation is not as concerning. Not that, and we learned that from Dr. Mustafa from the number of perforations he created, antegrade and retrograde. So we have a lot of experience.
All right, here we go, guys. Nice. This is a nice image here. All right, so George, what Fed is saying that his wire from below should actually, that's you, Fadi, right here?
Yeah.
Right? So why don't you come back to here and I'll put a catheter for you. All right, so Fadi actually is in a true lumen here, and I'm in a true lumen. So I'm gonna stop and basically take the IVUS out. And then we'll take an 035 catheter in, and then funnel it at this point. So George, that was a good opportunity for us to show you IVUS directed CTO crossing and a complex CTO.
But you have this type of CTO. I mean, not a lot. I think it's a wrong thing to attempt to cross it just in an integrate fashion. And I think the point that we're trying to make here is you need to start with retrograde access with this type of CTO. Yeah. Long, no pedal reconstruction. We're accessing occluded vessels.
So actually, if it wasn't a live case study, we don't start with the integrate at all. We just start with the retrograde. Absolutely. If we have previous angiogram. So George, the point Faye is raising, in this kind of CTO, the complexity of the CTO is so bad. Can you push it in? That don't try to get access from above if you can't get access from below, because really you can't do anything. You can't take it
You're exactly right, so, and you're exactly right about being able to access from below, because it facilitates crossing. And I think Fadi, correct me if I'm wrong, but your CTOP paper illustrates this, that you and Dr. Mustafa wrote together on CTOP crossing. Is that true?
Correct. So you really need to. This type of CTO has all the predictors of requiring pedal access. It's long. It's for all practical purposes a type 2 CTO.
We don't need it. We're just gonna what do you call it?
And
so we have that quick cross from above and 018 CXI from below. And now Fad's gonna advance his wire into the quick cross. Now, there's a loop down here, right here, that I didn't cross, but Fadi had crossed it from below.
Right.
So hopefully.
And I already have blood in my catheter, so.
So he's in a true lumen, just waiting for the wire to come up.
For those of you who don't understand the rendezvous and the synapse technique, it's been illustrated many times in the literature, and it's a good technique to learn. But it always takes another person, an assistant that you have with you. Martin, do you try to do this a lot? Do you use synapse a lot?
Yeah.
So is Fadi like in the lumen, or is he outside the lumen?
Can I see if I'm in the catheter?
Or is he? Let's see if he is or not. What do you guys think?
I think he's.
Check with IVUS.
Can you give us your wire, please? Stop wasting time.
My wire?
Yeah.
And take this out.
Yeah.
It looks like he's successfully into the catheter.
Yeah,
so
he doesn't know, George. It's okay.
He did.
That's the worst question you can ask me in. Are you in, by the way?
Oh man, you gotta take the high road a lot of times.
It's lunchtime. Yeah, come on, it's lunchtime.
Oh yeah. Oh, but here we go. We had a nearly non-existent lumen distally. We got a V18 wire retrograde, and actually now we have a sheath in it.
Which wire do you have? This is
so.
Yeah.
We're gonna go ahead and actually proceed with the therapy. So I'm gonna ask you guys, based on what I showed you so far and the complexity of the tibial artery and negative remodeling, which atherectomy would you like us to proceed with?
Kumar, what do you think? What do you think they should use for atherectomy right now?
Let's have the fluid on.
Orbital might be a good idea here.
It's too open.
Orbital?
Yeah.
Martin?
To PA lumen.
Or Brian, what would you use over there in Nashville?
Can we have I want to get a clear idea based on IVUS and C. I didn't quite see the level of calcification
right.
on lesion itself. That would help me guide, what I would do. But honestly, orbital atherectomy is
doing good.
A pretty safe choice.
And what about you, Paul?
Yeah.
I want to know how long it takes Eddie to get his hair done every morning.
Oh,
Who to get his hair done?
I'm embarrassed to be standing next to him. Actually, guys. I'm
George,
sorry.
you understand. You have a full head of hair like I do. The others don't, so it's okay.
I apologize to all the media that is watching today.
I'm sorry. I was just finishing the last case while you were eating lunch.
George, I think with the type of crossing we have, they have all the options open. So
Yeah, I think that you're right. I think there's lots of different opportunities here. The good news is, I think you mentioned it this morning, Paul, is that having a sheath down below any microemboli that, of course, disperse distally can be flushed out through the bottom. I think you mentioned that in one of the cases this morning. So I think that's a great learning point as well. But I think obviously,
hold the wire, please.
Orbital atherectomy, and of course,
laser behind here as well.
Laser.
Yeah, I agree. I was gonna say, while they have, since they have single wire control here, years ago, I turned open 014 wire to run IVUS from below, and then you can do your work from above, or vice versa, depending on the size of the sheath you have below. But with 014, you can go.
Brian, I like your idea, actually, Brian. Usually, when the vessel is bigger, you would do exactly that. We treat with atherectomy from above, IVUS from below, and balloon from below. So like one in, one out. And if you finish in efficiency and safety. So George and Brian, back to you on this lesion here in the pop. There's multiple tenon lesions. Do you want to treat them or not treat them?
Sue?
Personally, I think you should treat them if you've got the time, because number one, I think every lesion in tandem takes away a little bit of the perfusion pressure to the lower extremity, but that's my personal feeling. Anybody on the panel have any thoughts about treating lesions?
I do, George. I don't mind taking that question. So I think a CLI case is a process, like a painting, and we can't look at things just in silos. So he's painting a picture, and to leave it incomplete. And I love what you just said, perfusion pressure. We're trying to pressurize that foot to heal wounds. So look at it as a complete picture. Just take care of what you can with the best options. And, leave no lesion behind strategy, but just paint the picture you want to get the result the patient needs.
Yeah,
no, I agree. I agree with you there. So what are you using right now?
Switch to 3040, please. So we picked a 1.4 laser.
Okay.
And the reason 1.4, actually, in case anyone is curious, because of the negative remodeling distally. So we need something that can accommodate that and organize thrombus that is present there. We're hoping that we can hopefully alleviate some of it. Now, once we get here through, we'll open the sheath distally and allow for any micro debris to get out instead of going distal. And that's, again, it's a common sense that we do it. Since we have the sheath, then why not, right? So we do that.
Go ahead, open the sheath.
And then the sequential bone angioplasty, I really would like to iterate a little bit about this today.
Take half of it out.
So we're going to take a 2 by 300 balloon and then a 2530 and then a 3035. And then you'll be surprised, actually, how nice this artery will look toward the end. What do you guys think about this sequential balloon angioplasty?
Well, I think it's a good, let's ask Martin, what do you think about sequential angioplasty in the tibials and popliteals?
Sorry, I'm cutting in and out a little bit, but no, I agree. I think, honestly, I like laser for this case. I think sequential ballooning up to an appropriate size, especially will aid in, decreasing the amount of recoil as much as possible.
That's right. Recoil is not your friend, is it, Kumar? I mean, let's face it. I mean, you can come back 10 minutes later and all of a sudden I've got this frown on my face because the artery doesn't look as good as it did. So, but I do agree. I think sequential angioplasty is important.
Sorry to interrupt you. I just want to show the value of having a floss system. Ben, our interventional ultrasonographer, is pulling on the wire. I'm pulling on the wire, and Gia is having a hard time advancing the catheter, so we're going to keep pulling. Go ahead, Ben.
Okay.
Pull. Activate.
So actually, the procedure would have stopped here if we didn't have the retrograde access, because we can't advance. The other thing we could have done is we could have put a 7 French multi-purpose guide and put the laser through that. That's for additional support. But instead, we just use bend or an retrograde axis. And notice how slow we're all kind of moving here because we want to gain the most efficient benefit from the bubble of the laser. And when bend stops pulling, we can show you actually the bubble under ultrasound. So let me have Kristen go down to help. If you're doing the laser, sorry. Yeah, go ahead. Actually, go ahead and help. So Ben, can you show us an ultrasound, please, the bubble? You know, George, I want to show you if you go fast versus going slow with laser, what kind of difference it makes, okay? And why sometimes you can dissect if you go fast while you're lasering. All right, here's tip of the laser. Up a little bit more. Okay, activate it, please. All right, Ben will find it. Once he finds it, here you go. Now the vessel is negatively remodeled, small, and I'm gonna start moving it now. Patty's gonna start pulling it. So actually the movement is from below.
Go ahead, pull, Nate.
And all this sort of diffusion that you're seeing there is part of the energy from the laser, and it's being distributed evenly. The bubble is what here, guys? Can you name it? What happened to the bubble here? It's elongated, right? So in negatively remodeled vessels, the bubble gets elongated, and then it penetrates distally where it finds a lumen. So if you're wondering what are you looking at, all right, thanks, man. It goes into the sheath. That's good. Stop, everybody. Thank you.
It's a really great demonstration.
So this, you did. Have you guys seen elongated the bubble before? Sorry.
No, that was an excellent example. That was excellent.
I think if anybody's attended a Craig Walker talk, they've seen the elongating bubble.
Yeah. So elongating bubble does make a huge difference because now it's creating a path. We don't see it here, right? You just gotta keep going, and until we get to the end, and you're not able to pull. So even from below, they're having a hard time pulling.
Let go of the wire, guys. Okay, hold the wire.
All right.
I'm just doddering right now, and we can activate it later. But I just want to show, like, you're not going to be able to do this if we did not have a floss system.
Very true. Very true.
Catheter is coming back. Let's have that. We're going to start with. Yeah.
For people starting out, how fast would you recommend they go with the laser, Jihad?
Like I was doing earlier, very slow.
About a centimeter. Yeah, about a centimeter. Okay.
Yeah.
Centimeter per second or so.
1 centimeter. Yeah, 1 centimeter. But we all get impatient and we try to do it faster. When you go fast, you don't really get that much benefit. So in atherectomy in general, really, you got to go slow to finish fast. So fast laser cause dissection, fast anything atherectomy cause dissection.
You always say that, but you never follow these rules.
I don't have any dissections. What are you talking about?
Okay. You guys are the
go as fast as you want to crash.
Dr. Stafford, are you guys, if you're treating SFA, let's say with laser, or are you typically using a filter for those, or in general, are you feeling pretty comfortable without anything?
Yeah, good question.
That's why'd you ask that question today, Kumar? Let's see. Thank you.
So yes. I will tell you something that we do in our strategy. Whenever we have CTOs, ISR, or actually a traditional CTO, we've actually been doing thrombectomy on those patients. That's been my practice and Jihad's practice. And we do not necessarily use a filter. We rarely use a filter. And that's a paper that Jihad, you published with Dr. Davis, right? That showed the risk of embolization after following that strategy was extremely low.
That, and also we used a blood pressure cuff on the calf.
Yeah.
So
and for tibial vessels, I personally feel that putting a filter in tibial vessels is a cause of problem more than anything else. And the other thing, if you notice, our threshold to placing pedal sheaths is extremely low. So it acts as a poor man embolic protection. You're protecting the distal circulation. So So
well, it depends, Freddy. I mean, some of the IVUS you do, and you see like mobile thrombus, and
that's a separate story there. I mean, if you think that there's a thrombotic material, then the whole treatment strategy would change. But
let's go down, please.
Down from 4.
Can you go to?
You're right. If you do think that there is thrombotic debris, or what I can call congealed sort of old blood there, it's nice to be able to use some of the devices to remove some of that before you intervene. There's nothing wrong with that, but I think that's a great technique to add to your toolbox.
So, Kumar, to answer the question in general, though, every patient is different. And some patients, you need to have IVUS, and some patients you don't. And it's always going to be the operator's decision at the time if they use IVUS. I mean, please. We use IVUS most of it. Let's go ahead. Let's have the second balloon, please.
Well,
we use IVUS 100% of the time.
Down from 12.
Jihad, we wrote that paper with you and myself and Fadi. We wrote that IVUS versus angio paper that we published last year.
And your paper changed our life, George. Thank you. Yeah, go ahead. Talk about it.
And then we wrote that paper. We took 43 patients, and we used IVUS on every single one of them, and even from a pedal approach. And it changed the size of our balloons. It changed the length of our balloons, and it changed everything that we did. So IVUS is a very, very, and I'm not saying this for any other reason, but I think IVUS is a very important tool to get the best possible patency results. Would you guys agree on the panel?
George, based on your paper, I mean, our paper, but we can't, I mean, you're the author, first author, good job, by the way. It was a great idea. Based on that paper, George, we altered the course of therapy today for this patient, correct?
Right. I agree.
We're not going to treat the popliteal. So the course of therapy was altered toward a positive outcome. So without it, we would have missed high-grade stenosis in a CLI patients. And also without the IVUS, probably would not be as aggressive coming down from above in a true lumen because the retrograde wire was in a subintimal space. Right. So actually, look how much IVUS is added so far to the care of this
Ryan, we're having some pain.
So it's a great paper. I hope more people read it and follow the recommendation from it. So notice here we're doing about 1 minute per inflation. This is not our final therapy. So this is a 3.0. 2.5. So this is 2.5, 300. And after that, we're going to take a 3.0, 3.5 and inflate it proximally. Any recommendation or sizing, or do you want to re-IVUS? What would you like to do next?
Guys, what do you think you should do? Brian, what do you think you should do?
I think you guys know what I'm going to say. Re-IVUS it. Let's take a good look.
Take a good look. Okay.
I was going to show the balloon.
Kumar, what are you going to do in Chicago?
You want to inflate it?
I'd say a re-IVUS. For a lot of these lesions, especially these heavy tibial disease, I like to go after conventional balloon. I go with scoring balloon. I don't know if it's anecdotal. I'm looking at the numbers on our own, but I go really aggressive with the different type of balloon on these.
Martin, would you go just plain angiogram and see what you got, or would you re-IVUS?
I'd re-IVUS. I think it's really important to know exactly what size it is. That helps you keep this open.
I think I know Paul's answer.
Is that re-IVUS?
I'm not sure. It's re-IVUS, guys. It's re-IVUS. It's re-IVUS. Everybody on the panel said re-IVUS.
From below, probably. Yeah.
I'll take a picture from below.
You know what? We're gonna do a picture from below for you, just to give you an idea of how not so great things are. But hopefully we're gonna get them better soon. This is after 2.0 and 2.5 balloons. Ready? Sure. Okay. There's no dissection setting.
Yeah, because I access the vessel.
So, George, back to our discussion earlier. So, with the Schmidt access, the overall outcome for this patient is improved significantly. Without the access today in an occluded artery, this patient would not have a revascularized major tibial artery. So you see the evolution of therapy in CLI. I mean, it continues to evolve, and hopefully this will be a great distribution to everyone to start utilizing at their centers. And don't take the example of today as being the standard Schmidt access technique. Today, this case is extremely difficult. We just want to show something difficult, but usually the vessels look much better than that, and you can access them easier.
No, I think that's a great point. And our faculty this morning, I think we were talking about, everyone, including Dr. Zeller, that you've got to have a certain amount of experience to tackle difficult, complex lesions. Dr. Saab, let me ask you a question. When do you think people should start accessing occluded vessels if they've never done pedal work before? 100 cases, 50 cases? When do you think they should start tackling something like an occluded vessel?
Yeah, that's a great question, George. I think one of the most important thing is A, do they use ultrasound in their practice? Is it 100% of the time? And B, I think, and this is an arbitrary number, right? But
sure.
But I think 100 cases will offer you some comfort in understanding how these vessels look under ultrasound. Is that okay there? Yeah. Just you'll be able to understand these vessels very well on the ultrasound, and you'll be able to discern like which true vessel, what's vein. So I think 100 access like normal access points will be a reasonable target. That's what at least what I tell our fellows.
And can I have a 60 by 100? And
we have a 60 by 100.
Okay, thank you. So I think someone mentioned scoring balloons, so that's a good idea. Actually, thank you. We're gonna open one and use it. As you can see proximally, look at the vessel still looks like it's got a waist in it, despite the fact that we have a 3.5 millimeter of a balloon in there. So we're hoping the engine scoring balloon will help in this setting. So, and the way to use the, I think it was Dr. Fisher mentioned that. Brian, you want to tell us how to use your balloon when you use it, scoring balloon?
I think that was
Kumar. I think it was Kumar.
Oh,
I think it was
sorry.
Kumar, actually.
His name is Kumar.
All right, we'll go back to Kumar.
He's
not as good looking as Brian.
Look at the hairline. I'm sorry, Kumar.
Oh boy. The humility is abundant.
Down from 12.
For me, the nice thing about it, the downside of it is that usually I have to pre-balloon, especially in these small vessels, because it's hard to get the scoring balloon down there as a primary balloon. But once I get a pre-balloon in there, my next step is usually a scoring balloon. I go as far as, as whatever distal as I want to go. And I think the key is low, steady inflation. Yeah. Let the time work and give it time. And I keep it up for 2-3 minutes and then kind of move it a few millimeters to a centimeter back and then re-balloon that whole area, because the tine's going a crisscross fashion. So you want to move it so that you hit all parts of the vessel with those tines.
Yeah, that is really a great point. And this is how we've been using it in any lesion that we're trying to get an impact on or leave an impact.
Hey guys, how much time do we still have?
16 minutes and 52 seconds.
Yeah,
16 minutes and 52 seconds.
Let's start here. Let's go up here. This is the ostium. If you remember, we're having a hard time getting an ostium here, releasing its basically elastic coil. So we're going up slow. You're going to let the scoring element sit in. And then after 30 seconds, you give it a secondary burst of pressure. And hopefully you'll have a nice circumferential distribution of pressure and then dilatation that is equally distributed with no dissections. And Fadi is going to show you the scoring elements. Can you appreciate them, George?
Yes, we can. That's a good picture, actually. And I think that shows exactly what you're trying to accomplish here. There's been a lot of talk about just different specialty balloons in this area. Just to sort of poll the panel, Kumar, what do you like to use? Anything in particular? Just any scoring balloon, or?
I mean, what we have in stock and what I use. Is the one that.
Right. Martin, anything particular?
Yeah. No, same thing.
Paul. I kind of like. And what about you?
Cross.
Brian.
Yeah, I agree with Kumar on that one.
You know what I've used, guys? I don't know if I'm right or wrong, but I have used the chocolate balloon in some of these osteal lesions of the tibials. I've had good success with the chocolate. Again, I think there's lots of different ways to treat these lesions. but I have found that's one location that the chocolate seems to have done a good job for me. So.
I'm sorry, which location was that, George?
The ostial lesions of the tibials, typically, and the tibial perineal trunk. I find that it seems like it does a good job there, especially.
And this is the way this balloon in particular, you want to give it time to deflate, because the scoring elements on it, especially if you have a long balloon, can sometimes kind of be difficult to come out. But they have fixed the issue. It's not a problem anymore. But we still actually have old habits. Once you have, so now we're going to move on to get it into the dorsalis PS artery. So we're going to take the quick cross back in and show you how we're going to do that. And believe me, if I did not have support from ultrasound, I don't think I would attempt this. Would you, Fadi?
No, I mean, clearly there is no, take this out. Clearly we don't have any other way of visualization other than ultrasound. I mean, you don't have angiography. We can see that the vessel is occluded. So
we can give you both
go ahead,
AP and medial lateral views or medial views to show you. So to show you the pedal arch, but I don't think we're going to show you much.
Have a microcatheter in, or
I think anything will go in. You know what? LP will go through.
LP
014, yeah. Guys can have an LP 014.
So they mentioned the value of extravascular ultrasound. Getting the hospital to give you an ultrasonographer into your lab is pretty hard sometimes. Brian, do you have one in Nashville? Do you get one from the hospital easily?
No, I really
try
to techniques that I can get myself. I just worry about not having someone available if someone gets sick. But if it's something that you're able to parlay when it comes to the hospital system, I think it's a great idea. It's not an option for.
Can you guys switch to ultrasound, please?
Can you show the ultrasound, please?
Okay, let me go in sheet.
Kumar, can you get an ultrasonographer at Rush very often?
We do our own ultrasounding.
I'll follow you.
I do mine too.
Just by training.
Paul and Martin. Same thing.
Same thing. Yeah.
I like to do my own as well. If you do have the chance of getting one, though, I think it certainly adds to the efficiency of the case and the speed that you can do things, because obviously there's no doubt ultrasonographers can do things that we can't do. So I think that's important.
Let me do contralateral. Here you go. Look at the artery. I mean, it's so spastic and negatively modeled. We're just kind of making a lumen in it. We're trying to create. The lumen is there as collapsed. It just needs some attention. So we have a microcatheter coming in, and that microcatheter is going to help us. Here you go. This is the spec 14 LP, and it's a very low profile catheter, and we'll be able to put it through the quick cross. And you notice you have to stop what you're doing because any additional work here is not going to take us anywhere without the secondary support. So Fadi, you want to talk about telescoping system?
Yeah, so basically you have a triaxial system here. You have an integrated sheath, you have an 035 catheter, and then we have an 014, or this is an 014 catheter inside of the 035 catheter to get all the way where you need to go. And now you can let go. Now we're gonna advance that catheter all the way to our loop right there. And I like the loop actually. We should try to keep it once Jihad gets it there.
I think the catheter is so good that I think it's going to loop. It's on itself. 1 second, Ben. Let me see. The catheter, did it get there? You can't actually see it so well. Can you give me some spot from here? Oh, here it is. Okay, it's coming down. Okay, here it is, right here. So now we don't want to lose where we are because, so Fadi, go ahead. So Fadi is going to pull the wire and then redirect, stay in a true lumen. And Ben is going to help him.
Wow.
So you're in a lumen here, awesome. So that spec really provides good support. And Fadi, just something good here or bad? I'm not sure. Let's find out. Then yes or good? Yes or no? Yeah, you're right. Oh, distally? Yeah. Okay, awesome.
Would you like to say sorry?
I'm sorry. All right.
You still have to ask if you're in, though.
Can you take that back so we can... Yeah. No, it's really good for the patients.
Great, great job. Very nice. Very well done, guys. That was a very difficult distal AT and proximal dorsalis. So that was a great, great well.
Here you go.
Little branch there.
So you know what? Let's talk about this, guys, for a second. Let's take a picture. What do you guys think about getting a half loop for someone like this patient today? Get a good results and then come back another day and work on the PT, or actually take a picture now and then finish the loop today and then come back and do the PT another day. So let's discuss these two options, okay?
Yeah, I think given the multiple scenarios, I think you always have to have different plans. Paul, what do you think? What do you think for most of your patients? What do you do? Try to accomplish everything and keep them on there?
Everything needs to be taken in context of the location and the skill sets. So they have the ability to bring the patients back whenever they want. So he's not obstructed by a care pathway that's not efficient or resistant. So that's beautiful because you can stage. You don't have to bring somebody back with a lot of care pathway barriers. So I think establish wound-directed therapy, inline flow, and then stage the rest of the procedure. It's a great option.
I think that's great.
Yeah, you're right. So guys, what do you think actually was the most valuable tool today that helped us be successful in this case? Because quite frankly, we thought this was going to be extremely difficult, a lot longer. But
I think my hair.
Besides Fadi's hair, what was the second?
It probably took longer to do your hair than to finish this case, Fadi.
Guys, I think really honestly, to be honest, I think the combination of EVUS and IVUS here certainly allowed us to make sure that we're in the true lumen, that we had good flow down the arteries, and that we were able to access appropriately. So I think it's a great combination. If you don't have those things in your toolbox, certainly you've got to try to get them. I think that's important. Kumar, do you agree?
I think totally.
I agree.
You have a lot more confidence in your treatment by what you're doing by using these adjunctive tools. I think back to the question about fixing the other vessel and all that, and I think with these tools, our efficiency and our delivery is much faster, much better. So I think it gives us the option to treat more than one thing at once, depending on all the other factors.
Right, right. And I think that's one of the beauties of being able to stage people. I don't think there's anything wrong with that word at all. I think you've got to, you've got to do the best you can, perfuse the foot as much as possible, and, come back and treat again. Dr. Mustafa, what are your thoughts?
I'm with you 100% because we know if we get greedy and try to cross over, from experience, man, you learn a lot. So you try to get crossover and find the plantars, and you end up dissecting or causing spasm of the DP and the branch coming off of it. Then you lose everything because of that. And I've clearly experience teaches you a lot of lessons, good and bad. The good ones here is, you know what, this is great for this guy. He didn't have any of this before. Let's just stop here and bring him back another day. And this is where a lot of our colleagues will say, I don't know when to stop. I've learned from experience, when you get something this good in a patient that have a very difficult anatomy, walk away sometimes is actually, walking away sometimes is actually better than doing more. So we're going to walk away if everything goes well right here. Here you go. So that's a 2.5 balloon, okay? 2.5 by 300 balloon. And we're going to go up.
We had a question. Yeah. What wire were you guys using to cross that DP?
We use the same wire we started with. Which wire do you start with? The
command wire.
The command. We'll start with the command, and we'll finish with the command. It's a single wire. And, Kumar, to be honest with you, what crossed today is the ability to see where to go. So whichever wire we had would have directed it into the right direction.
Right.
What Ben is trying to show us here, and I really appreciate that. Thank you, Ben. What he's doing here is showing us, without us asking him, see the waist that is there? Can you show it again? He's showing us that the ratio between the balloon and the vessel are okay, but there's a waist right here. Here's one. And this is probably like multiple CTOs that were there that we didn't see them. And the ratio, though, you can see the balloon is touching the walls. So the ratio is 1:1.
That was a great point. Making sure that balloon is 1:1 with the wall. If you're seeing space between them, increase the diameter of your balloon. Correct?
Yeah, absolutely. And then Ben, can you go up toward the AT a little bit more? Yeah, thanks. So here you go. Look at this here. How actually you see this beautiful, connection between the wall and the balloon. And how many hemispheres? We're only 10 hemispheres. So I think this is great for this patient.
I always say if you're not touching the walls, you're not providing therapy. So you're just floating in free space. So
yeah, absolutely. So we're going to go down here 2 minutes and take some pictures for you guys. And we're going to fix the popliteal on our own because we only have a few more minutes with you.
We've got 3 minutes. Yeah, we've got 3 minutes and 47 seconds.
How's the blood pressure, guys? Okay, yeah, we'll just show you the result of what we just did. We're going to give 100 mics of nitro. Pressure is soft. And then we're going to do a subselective imaging. So, George, your paper's still helping us here. Data-driven, not class 1 evidence, but data-driven approach. So this image here determines the next step for next time, okay?
Right.
So now we know when we come back that we do have a way to go from the DP to the plantars and fix the posterior tibial and plantar arteries. Now the next picture is going to be to show you the access site. We get a lot of questions about the access site. So you might see some spasm. And if there is spasm, what would you do about it? So with the blood pressure that low, you actually take a balloon back in and you inflate it at low atmospheric pressure.
For how long, Gia? For how long?
Just a minute or two. That's it.
Okay.
So we'll touch that one. I mean, we predict that we're going to see it, but if you leave it alone right now and we have time and show you later, it will be gone. So
that's a superb result, guys. That's just beautiful.
Thank you, Brian.
Very nice.
Thank you, everybody.
Very well done. Very well done so far.
And then we're gonna show the recommendation by Dr. Kumar, our esteemed colleague here, who recommended uses scoring elements approximately. Thank you, Kumar.
Kumar, I think that was a sarcastic comment.
Oh my goodness, Kumar, that was
I would not take it, man.
Fadi is so jaded.
I think he's jealous of your hair, man.
That's definitely not nice.
That looks great, guys. That looks beautiful. That looks beautiful.
Kumar, that was a great suggestion, man. Thank you for recommending the NG score.
Can I have the wire again, please?
So, guys, this is really great, state of the art. Showing the fact that there's completely occluded vessel, negative remodel doesn't exist, and you get access in it, and actually you rebuild it. I mean, this is the future of CLI.
Yeah, and
we got to show IVUS run.
You want an IVUS run?
Absolutely.
How many minutes do you have?
As you guys go on, I've got a little housekeeping duties to do. Number one, we encourage everybody to visit the exhibit hall and connect with everybody. I think it's very important. 5 to 7, there are the workshops. So if everybody could get on the workshops, it would be a
Brian,
great
I'm sorry,
idea.
bro. We'll do it and show it to you later, okay?
And of course, there's posters up throughout the virtual part of the lab. So just go ahead and visit the posters. And again, we're all here for all of you for networking in the networking lounge. You'll see the whole panel and everyone available, including Dr. Mustafa and Dr. Saab when they're finished with the case. But honestly, that was a great case, Dr. Mustafa, Dr. Saab, and your whole team up there. Congratulations.
Great case.
Thank you very much.
Thank you, everyone. And thank you for this esteemed panel, really.
Thank you, guys.
Great panel.
Awesome panel. And thank you to Phillips for helping putting this CME course on today. Thank you so much, guys.
Thank you to Phillips as well. Thank you, guys.
Thank you.
Have a good day.
Thank you, everybody.
Thank you.